course.
Good evening, Vipin. Sorry, I didn't see you there.
Good evening, Arun sir. Good evening, sir.
Prakash, can we start?
Please go ahead.
Okay. Good evening to you all, and welcome to this first webinar of this sort, this type. Now, we in the gastroenterology fraternity felt this need to update ourselves about some aspects of internal medicine, for the simple reason that during the course of our so-called super specialization, many of us seem to have sort of lost touch with all the recent developments in some aspects of internal medicine. Diabetes was one of them. Cardiac diseases was the other. There's so many of them where we may have been outdated as far as our knowledge is concerned. So we thought that we'll make use of this forum to invite super specialists from other specialties to educate us about what is new in particular aspects of internal medicine. So today we've selected diabetes as our theme for discussion and updation. Diabetes is a problem that all of us face on a day-to-day basis, be it our patients with liver disease who've got uncontrolled blood sugars, be it a patient with viral hepatitis and diabetes who gets admitted and we want to control the sugars. So many areas, even our patients with inflammatory bowel disease who've been put on steroids, where the sugars go out of control. I think clinical situations are plenty. So we thought that we will take this as the first, and for the discussion. For the discussion in today, we have two of our fraternity members from endocrinology who have been invited. Dr. Arun S. Menon, who is the senior consultant and head department of endocrinology, Lissi Hospital, earlier with Amrita, and we also have with us Dr. Vipin VP, who is a consultant endocrinologist at Aster MedCity. So with these words, we'll go straight into that. This will be followed by a panel discussion where we'll be discussing about clinical case scenarios which we face, and we will get inputs from not only the two endocrinologists, but two senior gastroenterologists, Dr. Varghese Thomas and Dr. Krishnadas. So without much ado, we'll go on to the first talk. And the first talk is on newer oral anti-diabetic drugs and insulin molecules, an overview. Because over the last decade or so, it seems to us that the management of diabetes has undergone a sea change. We hear about a lot of molecules with complicated names. We need to know what is so special about them. We need to know about when we should use it. And so therefore, we thought we'll get Dr. Arun Menon in to talk to us about these newer molecules and overview. He will be talking to us for 20 minutes, and then after that, we'll go on to the next talk. Arun, welcome to ISG Kerala chapter. And you are a familiar face for many of us, and we we look at you as a person who can give us a lot of knowledge as far as the newer molecules are concerned. So over to you for your talk, Arun.
Thank you, sir, for the kind introduction. I think it's a brilliant idea from the ISG. I think we will all follow suit. I mean, clearly our knowledge when it comes to specialties like gastro is appalling, I would say, compared to your knowledge in diabetes. So I think there's a lot for us to gain by having this interaction. I think what I will do over the next 20 minutes, I think there's a lot of time we are going to give for discussion after this. So my role really would be to introduce these agents. Now, it is a tall task to talk about all anti-diabetic drugs and insulin. And mind you, in between this, there are some drugs which you can't call insulin and you can't call oral hypoglycemic agents. So these are the injections that we have, which are fairly wonderful drugs as well. So hopefully I'll touch upon that as well. I need to be aware of time. I'm sure GN sir will keep me on time over the next 20.
I will take the liberty of reminding you when you are about 2 or 3 minutes short of it.
Please, sir, that would be wonderful. That would be wonderful. Okay, thank you. So a very quick introduction, and I promise that I won't talk more about these drugs over the next 20 minutes, but that is our age-old drugs. And these have all have served us very well and continue to serve us very well. And I'm sure they will remain with us for a much longer period. I'm talking about metformin, the drug that has reinvented itself over the last few decades and has become more and more central to the management of diabetes, whether that be in the newly diagnosed patient with diabetes or for most complications of diabetes or people with most complications of diabetes. Metformin is fairly safe. We will, of course, discuss about hepatic this thing at later time. So that remains central even in the beginning, in the middle stages of diabetes. 30, 40 years later, metformin is there. It's always there. The sulfonylureas, again, I mean, it has had a lot of bad press over the last couple of decades. Why? Largely because we have newer agents, which certainly have benefits, but there is always that, trying to get the space. And the easiest one that people could target was sulfonylurea. And they are still wonderful drugs. And if you use it carefully, they give us wonderful results as well. So we can't forget the role of sulfonylurea now or even in near future or even well into the future. Thiazolidinediones, we know that the role of thiazolidinediones had gone down significantly since that rosiglitazone story. You might all remember over the last 15-20 years back, in fact, in 2000, when the rosiglitazone and its increased cardiovascular risk was exposed. And from then on, both rosi, which pretty much went off market, and pioglitazone, which actually has never shown that any increase in cardiac complications, had also fallen out of favor. But pioglitazone has made a comeback, and that is mostly due to you guys. You guys have taken it up and have realized the importance of its benefit as an insulin sensitizer and its benefits in fatty liver. However, there are complications with that as well, which are sometimes not very favorable for even liver disease patients. So all these drugs have got their own pluses and minuses. I will not touch upon too much on alpha glucosase inhibitors, which, as you all know, is a weak agent. And many times when the disease has progressed, and especially when patients are on insulin and that sort of thing, they really don't add much. And this is something which we see in prescriptions even now. So people are on bucket loads of insulin, but then they're also on a tiny dose of voglibose or acarbose. You wonder whether they're doing any benefit or whether they're just adding to the GI side effects of those patients. Then the meglitinides, which include the repaglinide and those group of drugs, which very much function like sulfonylureas and many times don't have too much more to offer than what sulfonylurea offers. So these drugs have limitation, and that is where the newer drugs that have come in have taken the center stage. So this is, in fact, having gone through a lot of changes over the last few decades in terms of the guidelines, and this is always hotly debated. Come January, when ADA comes out with the guidelines, everybody is on the bandwagon. Everybody wants to either support it or criticize it or whatever. But the long and short of it is that the newer drugs have taken center stage. Why? Because we have now moved from an era of just controlling the blood sugars, which is what medications are supposed to do, because that was a primary aim. We have moved from just controlling the sugars to actually dealing with reduction of complications of diabetes. So that is the focus now. So although we are treating diabetes, we are not just treating the sugar. The focus is really on treating the complications, which are predominantly the ASCVD risk and the CKD risk. And we know that most of our patients we lose over time, or any number of years, we lose them because of these two problems. That is, their cardiac complications and renal complications. Mind you, liver is following suit, and we are now seeing more and more of it, and I don't need to tell you about that. But this is just to show you that these two, that the newer drugs, which I'm going to talk about today, which is GLP-1 analogs, the SGLT2 inhibitors, have really, and the DPP-4 to some extent, or in fact, to a large extent, they have all taken center stage. Although in terms of risk reduction, it is GLP-1 analogs, I'll tell you which ones we are talking about, and SGLT2 inhibitors that is going to go on. So why is there such a lot of interest around the newer drugs? Most of these newer drugs are designer drugs. Why do I say that? They're designer drugs because once we understood pathophysiology, in fact, this now is an incomplete list because we have so many other pathophysiologies, including the gut microbiota, their role. So there are any number of other pathophysiologies that would add to this. However, the newer drugs are acting on, or they're designer drugs that have been made to act on some of these pathophysiologies. For example, the incretin is one of the targets, the other target being the increased glucose reabsorption from the kidneys. So those two are the main two pathophysiologies which have been targeted by the newer drugs. And that is why it is exciting, because we are now dealing with the pathophysiology. So I will focus on the incretins, which are the DPP-4 inhibitors and the GLP-1 analogs. I will then focus on the SGLT2 inhibitors and then on some of the newer insulins. So this is my list of medications that I'm going to deal with today: GLP-1 analogs, DPP-4 inhibitors, SGLT2 inhibitors, and then some of the insulins that you hear about, and the names sound all over the place, but they are just fairly straightforward insulins once you know it. So what is incretin? I don't need to tell you guys what incretin is. Incretin is that gut peptides or gut-derived factors, which the active ones are the GLP-1 and the GIP, which are released when you eat, and they're rapidly degraded by the DPP-4 enzyme. Once within 2 to 7 minutes, they disappear from the system. So you eat, they come out, and then they rapidly disappear because of the effect of DPP-4 enzyme. Now, what is the role of GLP-1 GIP? The main actions are on the pancreas, the beta and alpha cells, where they increase insulin secretion. So this is a glucose-dependent insulin release. So that is the action here. And at the same time, they shut off the glucagon or reduce the glucagon production from the alpha cells. So this is the pathophysiology we are talking about. So this is slightly differently, I'm just showing you, but just to say that the GLP-1 is released and the DPP-4 comes. And what we do with the drugs is by we in some way prevent the DPP-4 by inhibiting the DPP-4. So then with the DPP-4 inhibitor, which are the tablets, we get physiological levels of GLP-1 analogs, GLP-1. Whereas with a GLP-1 analog, okay, so the difference being with a GLP-1 analog, you get a supraphysiological level of GLP-1. So that is why GLP-1 analogs, the injections we have, are much more powerful than the DPP-4 inhibitor tablets. Okay, so that is in a nutshell what we what we get. So which are these agents that I'm talking about? If you look at the GLP-1 based therapies, which are so popular outside India, because one, cost is not a major issue there. It might be an issue, but their patients are still able to afford it because of the insurance systems. Here, that is the biggest problem. Second, being that they are injections. Now, if you look at it, liraglutide is the most popular one, has been around for more than 10 years. This is once a day injection. Dulaglutide, or what we call as Trulicity, is once a week injection. And then semaglutide, the most exciting one, which is a subcutaneous injection once weekly. But from next month, hopefully, we are going to have the oral semaglutide, which is once a week. And that will be released in India as well. Don't ask me the price, it has not come out as yet. But so what GLP-1 is doing is, these are injectable GLP-1 like substance, except for the oral semaglutide. They're not broken by the DPP-4 enzyme, which is why they're able to stay in your system for long enough and continue to produce insulin whenever you eat. And the weight loss is assisted. Weight loss is also the effect of incretin, but also the effect of nausea and vomiting, because clearly you have supraphysiological levels. Now, on the other side is the DPP-4 based therapies, which almost all our patients are on, isn't it? I mean, all the or many CLD patients, many patients who have had diabetes for a long time, patients on insulin are all on this DPP-4. So these are basically, they inhibit the DPP-4 enzyme, and they are oral, so they are oral tablets. They enhance the GLP-1. They are weight neutral. But the problem, or I could say, is that they are less powerful than these ones on these injections or injectable GLP-1s. They are very, very popular. The popular ones in India are vildagliptin. There are so many brands that have come out recently. Saxagliptin, which is less popular. Sitagliptin, very, very popular. The Januvia and those sort of drugs. Linagliptin, which is Trajanta, which is a very, very popular drug again, especially in CLD and CKD. Teneligliptin, which actually captured the market despite having least evidence of all these agents. So a quick comparison of this. A lot of it, I think I've on the top listed the main points to be discussed. The DPP-4 inhibitors are weight neutral, something that we need to understand, okay? The good thing about them is they don't cause hypos, okay? They don't cause hypos. If used on its own, of course, if you use it with insulin or a sulfonylurea, it's a different story. Again, you know this. Relatively side effect free, consistent effect. They usually give you a decent effect. It's not like, okay, one patient has an effect, one patient hasn't. They are by and large safe in liver, renal disease, and hepatic disease. There might be dose reduction that is required, or there is dose reduction required with Sita, Vilda, and Saxa. Linagliptin can be used in the same dose. Now, why is that? I think it's most to do with the fact that that is how it has been studied, and liver and Lina has got, I mean, these have more hepatic metabolism, whereas this one has more renal. Similarly, even in moderate renal impairment with dose reduction, you can use it. So they are very safe agents in renal and liver disease. When it comes to heart failure, there was concerns initially that some of these agents, especially vildagliptin, sitagliptin, might have some issues with heart failure, but all those fears have now been largely overcome, and we can use them, but we would usually prefer to avoid those agents in acute heart failure. Okay, so those adjustments might be required, but they are safe medications. These are just number of studies that have been done, very well studied molecules, and I think we can trust the results we are seeing. The class effect comes to the fore. I think I would say what you get is class effect. They're all, so the benefits are there with all of them. Now, let us move on to the GLP-1 analog. GLP-1 analog, the one we have in our market here, Victoza, which we use quite a lot, which is liraglutide, once a day injection, daily once injection, and Trulicity, which is once a week injection. And what are they? They are longer acting GLP-1 analogs, liraglutide, for example, with a 97% homology to human GLP-1 analog. And if you compare, see, you can see this is, I just put this slide to compare and say that when you compare it with DPP4, see the benefit there, it's 0.6%. In a lot of our patients, we see much more effect as well. So if you choose the right patients, you can get much more benefit with liraglutide 1.2 and 1.8. And added advantage with these agents, with liraglutide, is the weight loss you get, which you don't get with the tablets and the DPP4. So the 2.5 kg weight loss. And on top of all this, with the icing on the cake is the fact that they do have cardiac protection. These are wonderful studies that have been done. Leader trial is a very well conducted study, which actually showed that there is the primary outcome was achieved, and there was a 20% reduction in the 3-point MACE. Now, there is always concerns, isn't it, when it comes to this? And this is just to show in the leader trial what the adverse events were with these agents. And I'm sure this will all be of interest to you. There have been previously concerns that there is pancreatic side effects with this in terms of both the tendency to cause acute pancreatitis as well as pancreatic carcinoma. Now, this study certainly didn't show any increased evidence. There have been a lot of meta-analysis and pool studies which really haven't shown. I mean, these agents have been used vastly in the Western world, and none of the pooled analysis, none of the post-marketing surveys have really shown any definite increase in these problems. These are pretty bad problems, so we would be very scared to, cause it on our patients by ourselves. But still, this is reassuring in the lead trial. There is definitely an increase in acute gallstone disease, which was seen in this study. And the other agents, again, just to very quickly say, dulaglutide is the other agent that you should think of, monotherapy. So it's very convenient for the patients, pretty much similar effect to liraglutide. Lixisenatide is another one which is not that popular for some reason, but they are fairly same effects. Now we have, next month, we are going to, have the first and the only oral GLP-1 analog that is going to come out. Of course, I'm sure there'll be more drugs in future, but semaglutide has got 94% homology with human GLP-1 analog, GLP-1, and it is available in the oral form. And so that's a huge breakthrough, because this, I've heard many experienced people saying that the biggest thing that they are seeing is that this might be the breakthrough that we need to even have drugs like insulin come out as oral preparations. Because clearly, by using it in conjunction with an agent called SNAC, they have been able to break that gut barrier and get the medication in. So hopefully we will have more of such agents coming out, which either are insulins or behave like insulins. Wonderful effects with semaglutide, both in terms of HbA1c reduction and significant weight reduction, even up to 5 kgs. So I think this is a drug to look at. If the cost permits, I think we are going to see a huge use of these drugs. Now, the next part of my talk is on the SGLT2 inhibitors, perhaps the most exciting of this group. Why? Because they are all oral agents, and you know how they act. They are basically, they act by preventing the reabsorption of glucose from the proximal tubules. And there are many number of these agents: empagliflozin, DAPA, CANA, Andremo. You know all these agents, and most of your patients will be on one or the other. Again, class effect is what I would look at. I mean, there are, again, a lot of studies, a lot of cardiac studies and renal evidence. And the renal and cardiac protection is pretty impressive with all these agents, I would say. So these agents have been used in different patient groups, that is, people with very high cardiovascular risk to low cardiovascular risk, people with renal function across the board, and consistently they have shown benefits, cardiac benefits, as well as renal benefits. So in terms of improvement in EGFR, or at least preventing the GHFR from going down, and predominantly heart failure reduction. Heart failure reduction has been very impressive with these agents. So whichever you use, they all have that advantage. But if you go by evidence, it is empagliflozin which actually reduces, see here, the CV death reduction and heart failure reduction is best for empagliflozin. However, dapagliflozin seems to have a lot of evidence that has come out now. supporting its benefit again on heart failure and CV death, on LV remodeling, you name it, all sorts of cardiac issues. Now DAPA is actually hitting the news. So very, very impressive group of molecules. And add to that, there was initially a concern that because they act renally, maybe it may not work in people with CKD. It's true. It doesn't work in terms of glycemic reduction. So if you want significant reduction in glucose, it may not benefit much, it may not be of much use when the EGFR is less than 30. However, even in those patients, there is a renal benefit and a cardiac benefit when you use these agents. So now you're using these agents not for glycemic effect, you're using them for their extra glycemic effect. So that is why it is so impressive that these agents have actually changed their color and still remain in our prescription, not because they have hyperglycemia, but because they can protect people from renal disease as well as from cardiac disease.
Arun, we have just 3 or 4 minutes left.
Wonderful. I think I should finish in time then. Thank you. Now, in terms of side effects, I think this is one of the commonest side effects we see. So I mean, this is now a big concern because people are using left, right, and center. There are, I don't know, hundreds, but maybe around 100 SGLT2 inhibitor molecules that have come out, especially with DAPA going off license. Suddenly, these agents are being used by everybody. But then we are starting to see the problems because the urinary tract, people who have had urinary tract infections, people who I think many of, I mean, my job in a urology ward now is actually stopping these agents because most of the patients seem to be on these agents, and actually it might increase the UTI. So people who have got urinary tract infection, recurrent UTI, best to avoid these agents. Okay, the genital infections are still a cause of concern. The more we use, the more we will find that. Bone fractures was a concern initially, but don't seem to be so now. Ketoacidosis, this is going to be a concern as we move ahead. So it has been shown even from the earlier studies, from the initial studies, that in people who are insulin deficient, that means in type 1 patients and type 2s who behave like type 1, you know that a lot of type 2s who behave like type 1 because over time they kind of become very insulin deficient. Those patients, there is an increase of ketoacidosis that is pathophysiologically explained as well. But we are seeing more and more of this. Even last week, I saw a patient who has been on insulin and OHS for a long time, but somebody just a few months back had started an SGLT2 inhibitor, and this patient actually came with ketoacidosis. So we are seeing more and more of this because we are using more and more of these drugs. The amputation story, again, is not a major concern, but perhaps have to be careful when you use these agents in active diabetic foot disease. Now, quickly through newer insulins, 3 of them I just want to mention. The 2 that you need to know about are 2 basal insulins, and you could call them as generation 2 basal insulins. Which is generation 1 basal insulin? It is Lantus. So the generation 2 basal insulins that you need to know about are the one we call as a glargine 300 or Toujeo. Okay, so it is glargine, but it is a concentrated glargine. It's called Toujeo. And the other one is Tresiba or insulin degludec. Okay, and both, as you can see in this profile here, see how we have moved from a profile like this where NPH was causing still, although it was supposed to be a basal insulin, it was causing a rise in the levels, and whereas much flatter profile with glargine 100. Now we have moved to the newer insulins, much flatter, insulin degludec and insulin glargine. So very, very flat profiles with this. I will not go into the mechanism of action of this. Let me just skip these 2 studies. But the benefit here is that even over glargine itself is a wonderful insulin. Even when you compare with glargine, like for like, you find that there is less hypos, less severe hypos, less overall hypos, less nocturnal hypos with the same HbA1c. So that in itself shows that they're very flat profile insulins. They're very safe in renal and liver disease, and both of these can be used. There's not a lot to gain. Both are pretty similar. So perhaps some patients might respond to one better than the other, but mostly there's not a lot to choose between them. Some studies would say that glargine 300 is better than degludec, but it depends on which study you look at. Pretty much they all actually reduce the hypos, which is where their advantage is, flat profiles, and the benefits are for the patient. And this is very important for patients who have renal and liver disease, because they are the ones who have the most fluctuations, as we know. And of course, the pancreatic diabetes as well. Even they will benefit, but usually their basal requirements are much less. We'll hopefully discuss all that after Vipin's talk. Now, the last insulin I just want to mention, within the next 2 minutes I should be done, is the insulin Rhizodec. And again, the name makes it sounds very, very, very appealing, but it's nothing other than just insulin degludec with insulin aspart added to it. So it is basically the first mixed insulin, which is of this next generation. So we have had the Mixtard, the Novomix, and all that. Even Novomix is actually a mix of the Nova Rapid with our NPH kind of insulin. NPH is the basal insulin, the old basal insulin. This one has two analogs, okay? It's a co-formulation which has two analogs, which is insulin degludec plus the insulin aspart. And clinically, they are very, very useful. And I think I think pretty much everybody is very happy with the effects of this. Slightly more costlier, but definitely very good. So those patients who are on Mixtard or Novomix, when they are not getting better control, good control, certainly worth thinking of Rhizodec. And it definitely gives you better HbA1c reduction, better control of sugars, less hypos. Okay, so that is those are those. What are the agents in the pipeline? My last slide. There are a more number of agents coming out. The two I thought worth mentioning are, one is the one called sotagliflozin, which has been studied on type 1 diabetes as well as in type 2 diabetes. What are they? They are a combined SGLT2, SGLT1 inhibitor. And again, you guys know that SGLT1 is are in the intestine, and they delay the glucose absorption and therefore reduce, they're on the GI tract, so they reduce the glucose absorption and therefore reduce the postprandial glucose. So the hope is that these agents will have better effect than the SGLT2 inhibitors. They have even tried it in type 1, but there are concerns when it's tried in type 1 because DKA seems to be increasing. But type 2, this would be quite a good agent. Whether they will be a big advantage over the current SGLT2 inhibitors, we don't know. But very well done studies which have been published in New England Journal over the last year or so. And the most recent one that has been, that has again come out in the New England Journal a few months back is this one called tirzepatide. Okay, tirzepatide. And what are they? Again, very easy. They are basically a combination, a dual agent, which is a combination of GIP and GLP-1 receptor agonist. So we have got a combination of those two coming out. And they have shown that in SUSTAIN 2, there was one of the trials where they compared tirzepatide with the semaglutide. You remember the oral GLP-1 analog I discussed. So those two were compared, and they were this one was non-inferior to that. So equally powerful molecules, I would say. Again, this one I will not touch upon too much because I think Vipin is going to talk about this, but the agents for liver disease will certainly be GLP-1 analogs as well as some of the DPP-4 inhibitors. Again, that's for Vipin to discuss. So I would conclude by saying we are in an era of using new diabetic agents, new anti-diabetic agents, not diabetic, anti-diabetic agents, which are beyond glycemic benefits. Okay, you're looking at benefits more than just the sugars. And you need to commence these agents without delay if you trust all this data. And there's a lot of data. It's not as if this has been cooked up or anything. The data seems to be robust because with all these agents, there's consistent result. We still need to have judicious use of this in heart failure, CLD, and CKD. Just because we have these agents doesn't mean that we should use it in everybody. We might actually do them more harm than good. So I think my last line would be to say, guard against inappropriate use, because when these agents become cheap, there's a tendency to use this in everybody. I would guard against those. Thank you very much. I'll stop there and hand over to Vipin.
Thank you very much, Arun. I think exciting days ahead for people interested in diabetes. I quite like the terminology that you use, designer drugs. But I just want to know, what does this SNAC mean? SNAC, SNAC.
Yeah, SNAC is I need to, I'll tell you in a moment what it is, but basically in the discussion I'll tell you. But it is one of those, it is a carrier sort of thing, It is a molecule. I think I'm not sure whether it's a peptide by itself, but it takes, so it is inert. That in itself doesn't have any action, the SNAC, but it basically carries this GLP-1 into the into the
Yeah, we could
I'll
have
tell you what it is, but
yeah, you could have an update about that during the discussion time.
yeah,
But I
definitely,
think there's so much to discuss, and I'm sure that when in our panel discussion we'll bring up all these points. I'm glad that the last slide which you mentioned was about the liver disease, because that lets us go into the next talk. And the next talk is the art of glycemic control in patients with liver disease. I think this is a burning problem for most gastroenterologists. And given situations where you have liver disease and many of them are diabetics, it becomes a huge problem for us to actually decide whether we should go in for a specialist consultation, or we should take the risk of controlling the blood sugars ourselves. Should we use conventional insulin? Should we use newer insulins? So it is over to Vipin, who's the consultant endocrinologist at Aster, my colleague at Aster, very academic person. So that is why we thought we'll get him in for this discussion, and he's going to talk to us about art of glycemic control in patients with liver disease for 20 minutes. And after that, it is in for a panel discussion. Meanwhile, a request to everyone, please get the chat box going. You can post your questions onto the chat box, and I'd request Anthony to deal with the questions coming into the chat box. I will request Anthony to come in at an appropriate time. Over to you, Vipin.
Yeah. First of all, let me thank GN sir for inviting me for this presentation. And thank you, Arun sir, who has presented the topic of newer anti-diabetic agents as well as insulin in a brief and precise way. So my role is to present on art of glycemic control in patients with the liver disease. This is a topic which needs more discussions as well as more and more thought process to be put in. So I'll be discussing the topic in the following heading: the introduction part, glucose dynamics in liver disease, latest guidelines on the management of diabetes mellitus and liver disease, monitoring as well as target in patients with diabetes with liver disease, therapeutic options, practical case scenarios, which I came across in my clinical practice, and summarize my presentation. So if you see the introduction part, why the diabetes as well as liver disease are important, because diabetes, we know it is highly prevalent in patients with liver disease because of the fact of NAFLD, because this NAFLD is considered as the hepatic manifestation of metabolic syndrome. So majority of the patients who are developing chronic liver disease as a sequelae of NASH or NAFLD also has diabetes. And if you see the prevalence, it ranges between 14 to 71%, and the meta-analysis shows a prevalence of around 30%. And depending upon the liver disease also, it changes. The maximum prevalence is in NAFLD, followed by cryptogenic cirrhosis, followed by hepatitis C, and followed by alcoholic cirrhosis. And if you see what are the main factors which produces diabetes in a patient who is having liver disease, these are age, overweight, and a family history of type 2 diabetes mellitus. So these two problems are interlinked. And if you see what is the effect of this liver cirrhosis on glycemic control, it is associated with impairment of glucose homeostasis, because what is the mechanism for this abnormal glucose homeostasis? It is basically a defect in the glucose uptake into the liver. We know that when the insulin is produced in the body, it mainly acts by helping the glucose to be taken up by the muscle as well as liver. So there is a problem in the uptake in the liver part. So it results in sustained hyperglycemia. So when the patient is with liver disease is having diabetes along with this one, so patient is likely to develop ascites, encephalopathy, renal dysfunction, bacterial infection, HCC. So we have to screen patients with cirrhosis as well as chronic liver disease for the presence of diabetes mellitus, and these diabetes should be managed well so that it will reduce the mortality as well as morbidity. And this is a slide which just shows how much is the effect of diabetes on the mortality of patients or the survival of patients with cirrhosis. You can see a huge difference between patients who are having diabetes mellitus without diabetes mellitus and the survival percentage. All these p-values are significant. So poorly managed diabetes in a patient's liver disease increases to the or adds to the mortality as well. So if you see the glucose dynamics in a patient with diabetes and liver disease, what are the changes which is happening in the glycemic parameters? So we know that as the liver function deteriorates, the blood glucose excursions increases. That means hypos and hypers will increase. And the fasting sugars tend to be low or normal, which can be deceptive in this population. Majority of the patients may say my fasting sugar is always normal, but if I see my postprandial, it is on the higher side. So mainly postprandial blood glucose is elevated. Post-breakfast, post-lunch and pre-dinner blood glucose are elevated due to poor hepatic glucose uptake. And if you see the hypoglycemia, the chances of nocturnal hypoglycemia is high. And even if you treat a patient with severe hypoglycemia in liver disease, it can be very severe. It can be very difficult to treat because of the poor hepatic glucose reserve. Because we know that one of the important aspect of treating hypoglycemia is by giving injection glucagon. If the patient is having severe hepatic dysfunction, the glucagon is not going to work, because the main mechanism by which glucagon acts is by increasing the hepatic glucose output. So this is a typical profile of a patient, a CGM profile of a patient with chronic liver disease. You can see here the nocturnal blood glucose is on the lower side, and suddenly the postprandial blood glucose are increasing, and throughout the daytime it is on the higher side. And suddenly there is a dip in the postprandial post-dinner time. It is coming back to the normal range or hypoglycemic range, and you can see the nocturnal hypos in these patients who are having chronic liver disease. So CGM also help in identifying the nocturnal hypos as well as the glycemic excursions the patient is having. So this is a study which has showed the glycemic excursions, or what is the sort of glycemic variability in patients with type 2 diabetes mellitus and liver disease using a CGM device. So as I discussed, when we see the mean glucose values as well as the delta blood glucose, that is the difference between the highest and lowest values, it is significantly higher in patients who are having worst liver function. And postprandial hyperglycemia is seen in almost 92% of these patients, and nocturnal hypoglycemia was seen in 22% of the patients. And you can see the mean amplitude of like glycemic excursions and mean blood glucose values. All those levels were higher in cirrhosis as compared to chronic hepatitis. And this is the beauty of a CGM device, which can identify the hidden abnormalities of glucose fluctuations in CLD with type 2 diabetes mellitus. So we can utilize more and more CGM devices. Where is the defect, and we can correct it accordingly. So the next few slides of my discussion is based on the latest and the recent update of the management of diabetes mellitus in patients with cirrhosis, an overview and the joint statement. This is by the French Association for the Study of Liver Disease, as well as the Francophone Diabetes Society, basically the French guidelines, we can say. This is published in September 2021. This is the latest guidelines I could get. So as per these guidelines, when we are applying some of the criteria or the guidelines in a treatment population like a cirrhosis or a chronic liver disease, we should have a uniform classification of cirrhosis for the clinical practice. So what they have done is, they have divided this chronic liver disease or cirrhosis patients into those patients who are having a preserved liver function and an impaired liver function, with slightly impaired, moderately impaired, and severely impaired. And they use the child scoring also. Child A with compensation, they have preserved liver function. Child A with some abnormality in prothrombin bilirubin is considered slightly impaired. And this is one of the simple way to classify the patients with cirrhosis for the management aspect as well. So this will help you to get an idea regarding how much OHS can be used and insulin can be used, etc. So first of all, this is a uniform classification should be in place rather than looking up for the clinical symptoms and other features. And regarding the diagnosis of diabetes mellitus and chronic liver disease, if the patient is having cirrhosis and preserved liver function, you can use the standard guidelines: fasting sugar, postprandial blood glucose, and HbA1c. But the situation is complicated if the patient is having severely impaired liver function or anemia, where the HbA1c is not a reliable marker. So you should rely on the fasting plasma glucose and a 2-hour OGTT after 75-gram glucose. So if the 2-hour value is more than 200, you can say the patient is having diabetes mellitus. This is regarding the diagnosis of diabetes in CLD. And regarding the monitoring part, to see the glycemic control in diabetes and liver disease, HbA1c may not be a good option in all patients with cirrhosis and diabetes mellitus for the glycemic control. So it becomes unreliable when the patient is having anemia or impaired liver function. So HbA has to A1C has to be taken with a pinch of salt. And other parameters like fructosamine is also affected by hypoalbuminemia. So what is the best method to see the glycemic control in a patient with liver disease? It is basically self-monitoring of capillary blood glucose, or we will say SMBG. So this is the main thing that we are looking into for the day-to-day practice for the management of glycemic control in patients CLD. And definitely I said the CGM, that is a flash glucose monitoring system that is available for around 2,000 rupees nowadays, like a Abbott Liver Pro system, which can also be used for the continuous glucose monitoring in such patients, which can detect nocturnal hypoglycemias as well as fluctuations. So this can be utilized for patients who are having uncontrolled diabetes or nocturnal hypos. So then coming to the glycemic target. So whether we should apply the normal target for all patients with liver disease, but if the patient is having cirrhosis and preserved liver function, you can follow the standard ADA guidelines, target HbA1c less than 7%, pre-meal blood sugar between 90 to 130, and post-meal between 130 to 180. As the liver function deteriorates, mainly the prognosis of the such patients is depending upon the liver-related complications rather than the diabetes complications. So if the patient is having moderately or severely impaired liver function, the target blood sugar should be between 100 to 200 milligram, the pre-meal values. So don't worry if the patient is having a pre-meal value around 180 milligram per deciliter or 160 milligram per deciliter. As long as he's not having any hypoglycemia or any hyperglycemic symptoms, it should be fine. So this is regarding the glycemic target when the patient is having severely impaired liver function. So this is in a nutshell that I have discussed regarding the monitoring and the glycemic target. Monitor with HbA1c if the patient is having preserved liver function, self-monitoring of blood glucose if the patient is having impaired liver function. Glycemic target for HbA1c and pre-meal blood sugars as per the ADA ESD guidelines for preserved function. And under insulin therapy, the preprandial blood glucose should be between 100 to 200 milligram per deciliter. So moving to the investigation part, how will you manage a patient with diabetes and CLD? What are the important parameters that you should have, at least when you are starting the treatment plan for the patient? Definitely a self-monitoring blood glucose or a sugar monitoring chart. In mild cases, you can have a fasting or PPBS blood sugars, HbA1c, creatinine, as well as eGFR calculation, because many of those patients with chronic liver disease may be having a renal impairment as well, which requires dose modification of OHAs. Then electrolytes, LFT and INR definitely, thyroid function, urine routine, microalbumin, ultrasound abdomen to rule out a chronic pancreatitis, because some of the patients with chronic liver disease may be having an underlying chronic pancreatitis, and we may be wrongly treating them as type 2 diabetes mellitus. Fundus examination, foot examination, cardiovascular assessment in selected cases. These are the important things that as in a routine practice you should have at least once in a year for a patient with type 2 diabetes mellitus and liver disease. And the management start with lifestyle changes. We know that the proper diet is the most important part to start with, depending upon the lean body mass of the patient, because patient will be having ascites, edema, etc. So calculate the lean mass of the patient, and depending upon lean body mass, you can have the calorie calculation. Generally, 1,600 to 1,800 kilocalories per day will do. And you should also cover for malnutrition. Majority of the patient will be having an associated malnutrition, hypoalbuminemia. And the standard dietary intake is 25 kilocalories per kg per day, and protein intake, 1 to 1.5 gram per kg per day can be given. And the most important thing is patient may be having nocturnal hypos. So taking snack or milk at bedtime, this is called a split meal, is effective for the nighttime and early morning hypoglycemia prevention. And next part is doing exercise. 30 to 60 minutes per day of exercise, like aerobic exercise. So walking will help in patients to control their blood glucose, and 2 to 3 sessions per week of strengthening exercise, like a stretching exercise, will help in maintaining their muscle mass as well. Avoid smoking as well as alcohol is important for the management of diabetes and CLD as well. Sorry. So again, we have discussed one of the consensus statement on the dose modification of anti-diabetic agents in patients with hepatic impairment. This was published in 2017 in IJEM. So this is one of the important articles also to look into how much is the dose modification required. When I went through both these articles are having the same consensus. So we can have a general discussion based on these two articles. So what are the challenges in management of diabetes in patients with chronic liver disease? Because they are having associated renal impairment, they are having altered metabolism because liver is the primary site of drug metabolism for many of these OHAs. And patients with a hepatic impairment will be having more insulin resistance, and the insulin degradation also happens very late, very slowly. So they can have hyperinsulinemia, which can lead to hypoglycemia later on. If the patient is having associated sepsis or hemorrhage, patient can have lactic acidosis. So using metformin in such decompensated liver disease may be problematic. And malnutrition is another thing which is adding to this, along with sarcopenia. So if you consider metformin for the treatment of liver disease, because we know that the metabolism of metformin occurs very less in liver, mainly it is excreted through the renal system. So it can be used in patients with cirrhosis and preserved or slightly impaired liver function. And dosage should be adapted with the renal function. That is the importance of calculating eGFR. So if you use metformin in patient type 2 diabetes and cirrhosis, what are the advantages? There is an increased rate of survival. It reduces all-cause mortality and reduces risk of HCC development in some of the studies. And if you see in moderate and severely impaired liver function, if the patient is having severe decompensation, to avoid the complications of lactic acidosis, you may stop metformin. What is the dose recommended for metformin? You cannot give 2.5 or 2 grams of metformin per day. Generally, 1 to 1.5 gram per day is the recommended dose for metformin. And if you see the pioglitazone as well as acarbose, pioglitazone, we know that it's an insulin sensitizer. It can be used in patients with liver disease with a slightly impaired liver function or preserved liver function, but it is having side effects like fluid retention, heart failure, and edema, etc. So it should be avoided in patients with moderate or severely impaired liver function. Acarbose is one agent which can be safely used in patients with all stages of liver disease, but when the liver disease advances, the risk-benefit ratio of this molecule reduces, so it can be avoided in severe disease. Otherwise, acarbose is a good agent which can be used in mild to moderate cases. And sulfonylureas and meglitinides. Generally, if you consider sulfonylurea, only second and third generation sulfonylurea should be used, like a glimepiride or a glycoside or a glipizide can be used. And you should use this with a half dose or a lower dose to prevent hypoglycemia. It is contraindicated when the patient is having severe dysfunction or moderate dysfunction. And between repaglinide and nataglinide can be used in patients with liver dysfunction. Repaglinide should be avoided. And coming to the DPP-4 inhibitor, we know that the DPP-4 inhibitors are one of the safest agents to be used in patients with kidney disease, liver disease, heart disease, as well as elderly population. So there was a hot discussion regarding vildagliptin in liver disease. As per the guidelines, also vildagliptin should not be used in patients with cirrhosis and impaired liver function. Sitagliptin, linagliptin, saxagliptin, alogliptin can be used in patients with slightly or moderately impaired liver function. And in severe dysfunction, you cannot use. But there are data on linagliptin, that means Trajanda or Ondiru, where linagliptin can be used in patients with severe liver dysfunction, and it is having good glycemic efficacy even in such patients, and it is not adding to any of the complications of liver disease. And regarding the SGLT2 inhibitor, as Dr. Arun discussed, they are having a beneficial effect on the NAFLD pathogenesis because of the visceral fat loss, and it undergoes extensive hepatic metabolism. So there is insufficient data for the use of SGLT2 inhibitor in patients with cirrhosis. But there are certain situations where SGLT2 inhibitors are beneficial, like an obese patient with child day cirrhosis, where a patient can have good glycemic control and weight loss. And post-transplant diabetes mellitus, if the liver functions are normal, again, SGLT2 inhibitors can prevent further occurrence of fat accumulation in the new liver. So these are the two scenarios where SGLT2 inhibitors can be used upfront. So as the liver dysfunction increases, there is an accumulation of these agents. So it should be avoided in patients with child B as well as C. And there is a risk of dehydration, hypotension. So it should not be used in patients who are having decompensation. And GLP-1 receptor agonist also we have discussed in detail. We are having exendin-based therapy like exenatide and lisdexamfetamine, which should not be used because there is lack of evidence regarding this molecule. But on the other hand, the longer-acting molecules like liraglutide, dulaglutide, and semaglutide can be used in patients with preserved or slightly impaired liver function. But if the patient's liver function deteriorates, it should not be used. And the problem with these GLP-1 receptor agonists are they can have nausea, vomiting, and it can aggravate the malnutrition in patients who are having chronic liver disease. So nutrition assessment should be done at the beginning of the therapy of with the GLP-1 receptor agonist, as well as on follow-up. If the patient is having significant weight loss as well as malnutrition, then it should be stopped. And these agents are being tried well in patients who are developing post-transplant diabetes mellitus to prevent the metabolic complications and worsening of liver function as well. And insulins, as we discussed, it is one of the agents which can be used in any stage of liver dysfunction. But the most important thing, it can produce hypoglycemia. So titration is the most important key. And generally, patient require a basal insulin along with the prandial insulin to control their blood glucose. And if you are using a prandial insulin, fast-acting insulin analog should be preferred because it will produce, it will prevent the immediate postprandial hyperglycemia and late postprandial hypoglycemia. So this is in a nutshell regarding these different agents. But my question was, is insulin the preferred treatment in persons with type 2 diabetes mellitus cirrhosis? But you can have a latest article which was published in BMC Gastroenterology in 2021. If you use the if you see the comparison between insulin users and non-users, insulin users had increased risk of death, liver-related complications, cardiovascular events, and hypoglycemia as compared to non-insulin users. So you can see all the odds ratio here, which are all significant for insulin users versus non-insulin users. So it is not a fair idea to use insulin in a patient who is having a liver disease and diabetes mellitus with a preserved liver function. That is where the newer agents like an SGLT2 inhibitor, GLP-1 receptor agonist, and our grand old metformin still is an important agent to prevent all these things. And this is a slide which is showing the maximum recommended dose of these agents. Metformin maximum dose is 1.5 grams. Sulfonylurea dose should be halved. Pioglitazone only 30 milligram per day. Insulin, when we are using, it should be 25% reduction should be allowed for patient CLD to prevent hypoglycemia. And DPP-4 inhibitor, no dose adjustment is required. And if you see the cardioprotective and renoprotective effect, only SGLT2 inhibitor and GLP-1 receptor agonist are having this effect in patients with liver disease as well. So this can be used if the patient is having high cardiovascular disease risk along with preserved liver function in a patient's cirrhosis. So I'll be going to some of the real case scenarios to highlight the importance of juggling with these agents. So this is one of the case patient who presented with the type 2 diabetes mellitus as well as chronic liver disease. His HbA1c was 10.4 and he was on glimepiride with metformin 1 milligram by 500 milligram BD. So he was always sure that he was taking these medication, all his fasting blood glucose were normal, like 130 to 140. But he was never accepting the fact that blood glucose was on the higher side or the HbA1c was poorly controlled. When I asked him to monitor, you can see the postprandial blood glucose is really on the higher side and the pre-dinner blood glucose also on the higher side. And in the night, the blood glucose was falling when he is not having proper food. So this is a typical example of the glucose kinetic of a patient who is having chronic liver disease and diabetes. Normal or deceptive fasting plasma glucose with high postprandial plasma glucose and the pre-dinner as well as post-dinner blood glucose as well. So this patient required an upgradation of treatment. This is another case, case 2, where the patient was on a basal insulin glargine 12 units at 10 p.m. and a Janamet. This is a combination of Januvia with metformin 50 by 500 2 times a day. You can see the fasting plasma glucose. He was adjusting the fasting plasma glucose depending on the Lantus dose depending upon the fasting plasma glucose, keeping a target between 90 to 130. But you can see the HbA1c, it was 9.2. Then he started monitoring the postprandial blood glucose. So it was on the higher side. So he used acarbose to control the postprandial blood glucose. But again, the blood glucose, the HbA1c values were not coming down. So when we asked him to monitor the pre-dinner and post-dinner blood glucose, you can see the values which was really on the higher side. So the basal insulin alone was not working for him. So he was shifted to a mixed insulin with 50% short acting and 50% intermediate acting insulin, like 1608. With 8 units, he was getting some nocturnal hypos. So it was 16 and 6. With that, his blood glucose were fairly controlled and the HbA1c came down to 7.4. So this is an example where patient required a premixed insulin rather than a basal insulin to control the blood glucose value. And this is another patient who was put on insulin alone, stopped all the OHs when he was diagnosed to have liver disease. You can see the dose the patient was taking like 686 total dose of around 20 units per day, but still the blood glucose were on the higher side. He was having weight gain as well as post-dinner hypos. So what the patient was telling is his blood sugars were well controlled when he was taking OHA. So we also thought his point is valid. He's taking less than 20 units of insulin per day. So we stopped the actrapid and added him on metformin as well as an SGLT2 inhibitor. So he lost weight, and you can see all the blood glucose were well controlled without insulin. So still patients can be benefited with an OHA if the liver function allows you to give an OHA. This is another patient was on the standard therapy with a premix insulin, like a mixed-start insulin, 16 and 14. You can see all the fasting plasma glucose were well on the lower side and pre-dinner blood glucose on the higher side. He was increasing the nighttime insulin to control the pre-dinner blood glucose, but he was getting morning hypos. So when he was monitoring his pre-lunch blood glucose, it was on the higher side. So again, we added a rapid-acting insulin in the morning as well as lunchtime. So it came down, and nocturnal insulin should be reduced to prevent further hypos. So you can see the blood glucose improving with a rapid-acting insulin being added to the regime. And this is one of the last scenarios that I'm having. A patient on basal bolus insulin like Fiasp as well as Lantus with higher doses, blood glucose on the higher side. But when we added a linagliptin along with the metformin, you can see the insulin doses were reduced and the blood glucose were getting controlled. So you can use OHS plus insulin if the patient's liver function allows it to be used in such scenarios. So these are some of the practical cases I wanted to discuss. And if you can see the guidelines or the algorithm for the management of type 2 diabetes mellitus and CLD, you should have a high index of suspicion for diabetes. Check depending upon the severity of liver disease with HbA1c as well as the fasting as well as postprandial blood glucose. No cirrhosis, then you can continue with or start with metformin. Go with GLP-1 receptor agonist or SGLT2 inhibitor, and then add pioglitazone if the patient is non-obese. Compensated cirrhosis, you can continue metformin. Avoid sulfonylureas and meglutinides. Alpha glucosidase can be used if the blood glucose are not so high. Then liraglutide or DPP-4 inhibitor except vildagliptin is a choice. Then pioglitazone. Then you can see the insulin, where the insulin comes for a compensated cirrhosis. This is our last one. And for a decompensated cirrhosis also, if the patient is not having that much edema or need significant water retention, you can still consider low dose metformin. You can use an alpha glucosidase inhibitor still in this scenario, but generally other OHS should be avoided. So short-acting insulin along with frequent dose titration can be used. So this is the updated guidelines which is coming up, which still indicates that insulin can be pushed down and other OHS can be used. So my summary and take-home messages slide includes there should be a uniform classification of severity of chronic liver disease, which is required for the application of these guidelines. HbA1c becomes unreliable in patients with advanced liver disease and anemia. Glycemic target varies as per the severity of chronic liver disease. OHA can be used safely in patients with preserved liver function or mild dysfunctions. Insulin is not always a treatment of choice. Individual case-based approach is needed for the co-management of diabetes and liver disease. Thank you for your patient listening. And once again, thank you for the opportunity.
Thank you very much, Vipin. I think both Arun and Vipin, thank you very much. The talks were quite brilliant, a lot of information. And I think now it's time to move over to the panel discussion. And I'm joined by Dr. Prakash, who along with me will steer you through the panel discussion. Prakash, if you could share the questions for the panel discussion. And I'm sure Anthony is getting ready with the questions from the chat box. I do see quite a few questions from the chat box. So it will take a lot of effort and a little bit of time to do justice to all these questions that have come in. Prakash, can we have the first, or should I do it? Can
you do that, please?
Okay, I can do that. Right. Thank you. Okay, so for the panel discussion, I think we are joined by Dr. Varghese Thomas as well as Dr. Krishnadas, and of course, Arun and Vipin will continue. And the theme for this panel discussion is management of diabetes in gastroenterology practice. Essentially, maybe a revision of what has been told to us in the last two talks, but I think to give it a little bit of a clinical and a practical perspective. So that is how we're going to take it up. So I will now first go to metformin. Now, patients, we've been thinking that metformin is something that should not be used in liver disease. And then we were told that metformin has got its own advantages in patients with liver disease. I'm talking with reference to alcoholic liver disease and the use of metformin in alcoholic liver disease, especially in people who continue to drink. Arun, are there any concerns, and would you really change metformin into something else, or should we continue with metformin for some of the advantages that it has in patients with liver disease?
Yes, sir. I think slightly difficult question. It has to be based on the patients, but by and large, I'm usually not concerned. So that would be my first statement there. Because if you look at the concerns around metformin, even in patients with CKD, which is where the biggest concern is, it's around lactic acidosis. Okay, lactic acidosis is a concern. Now, if you have a patient whom you feel is going to decompensate very quickly, so this is why, as Vipin was saying earlier, it is a case-to-case decision. So for most of my patients, or most of your patients that I see, if they are stable, and if you feel they are not, they are not completely going off the rail, I would be quite happy to continue the metformin. Whereas if the signs are that this guy is unfortunately, sort of slowly falling off the perch, then it's a good idea to stop metformin and look at other agents. So I think it will be very much case-based. The lactic acidosis has been overplayed over the years. I think that is my first thing. There have always been this concern that, now we know that we can even use it in CKDs, in EGFRs, even up to 30 or even below. There are some patients who are on it. As long as the renal function is not going off, even the nephrologists now are happy to continue that. Safety, of course, is paramount. I'm not in any way saying that we should do anything unsafe. So the moment we are uncomfortable as a clinician, we should stop it. One warning being that when you actually stop the metformin in many of these patients, especially when they're on insulin or other agents, their glycemic control just gets completely out of hand. So we have had patients where we have stopped it, and then unfortunately we had to start back on a smaller dose. Depending on the dose, 1 gram to 1.5 is what is recommended now. Not to use more than that is what is recommended. I don't think that's based on very firm clinical evidence, but I think that would be still a decent dose to use. So use a smaller dose of metformin, use it in most of your patients, but if you feel the patient is unstable, by all means stop it.
I think that's quite encouraging actually, because you and Vipin have told us that metformin can be used and maybe should be used in patients, especially in child's A or even child's B, and for all its advantages. Yes.
Yeah, I agree completely with Dr. Arun that metformin should be used in patients with chronic liver disease unless they are so decompensated, they have a child score of 11 or 12. Because most of the studies have shown that lactic acidosis incidence is not much higher in patients with diabetes mellitus who have been treated with metformin as against patients not treated with metformin. And another thing is, in chronic liver disease, if you have a decompensated disease, we have got additional comorbidities in the form of renal failure or a cardiac failure, then it may be wiser to reduce or withdraw metformin. Otherwise, metformin should be given. It is the cheapest drug available and is one of the best drugs available. And it has been shown even to decrease the incidence of hepatocellular carcinoma and other malignancies.
I think point very well made, and we are actually revisiting metformin as a molecule of choice in our patients with chronic liver disease and diabetes. Arun, you wanted to make a point.
No, that's fine. I agree completely with Krishnadas. I think it is.
Arun, I have a small question to ask you. Many of our patients with cirrhosis, they get admitted because of some complications like GI bleed or sepsis. So at that time, before the admission, they might have been on an oral anti-diabetic drug, including metformin. And once they get admitted, what would be your strategy to control this diabetes at that time?
In hospital setting, I would stop, for most patients, I would stop all OHS. I mean, I'm talking about an unstable patient who has had a GI bleed or one of those reasons, or has decompensated and is on your ward. I would prefer to stop it largely because we don't know what all complications the patient is going to develop. Is the patient going to develop sepsis, or has the patient got sepsis already? So in an acute setting, my approach is always to stop the OHS, treat with insulin, and then review even before the patient actually gets out of the hospital, if that is possible. Of course, a lot of reasons why we may not always be able to do that. But, and then if that patient is having recurrent hospital admissions, then we should seriously start to consider whether these OHS, especially metformin, should be continued. And as Krishnas was saying, if there is a touch of CKD there, which is, then you have to be doubly careful. It also depends on other agents that these patients are on, isn't it? Say, suppose these patients are on quite a lot of diuretics and all those things. So those who have chance of dehydration, dyslipidemia, those sort of patients, if they're unstable, we would be much more careful. But in acute setting, I would stop metformin. I would stop SGLT2 inhibitors as well. I think that is one agent we should stop even before metformin, I would say. But both agents, yes. Vipin, do you want to add anything at all on that, or?
No, sir. Actually, one of the situations where we should not use metformin is when the patient is developing sepsis or hypotension because of massive GI bleed. Because other than that, the chances of lactic acidosis by using a metformin in chronic liver disease is very, very less.
Okay, I think we go on to the second question, and this is, I think we did cover this. Varghese, do you have to add anything to this metformin and insulin use in patients with chronic liver disease, the good and the bad, or maybe the ugly? Now,
Yeah.
Obviously, with many of our patients with chronic liver disease who are on oral hypoglycemic, especially metformin or other molecules, get admitted with a GI bleed or a sepsis or an acute and chronic liver failure. What do you think would be the best practice for all of us?
Can you repeat? The patient are getting admitted with acute liver failure.
Yeah,
what will be the ideal drug?
Acute. What would be the best practice to follow for all us?
Oh, okay. You mean like an acute hepatitis or acute on chronic liver failure or
acute hepatitis? I think we'll come to that later. I'm talking about a clinical scenario where a cirrhotic on fairly well controlled on oral drugs gets admitted for an acute problem. It could be an acute kidney injury or an acute and chronic liver ACLF. What would be the best practice?
Okay, when a patient with chronic liver disease as an acute insult superadded onto a chronic liver disease, regarding diabetes control, the risk of hyperglycemia is very high. That's the most important thing. So ideally, that patient with multiple organ problems should stop all OHA. That is the ideal thing. We should not continue with the oral hyperglycemic agents, and the patient should be on a frequent glucose monitoring. And if there is hyperglycemia, that has to be tackled with short boluses of short-acting insulin. That is the way it has to be done. So there has to be tight glucose monitoring as well as control, and ideally such patient will be in the hospital. So it will be possible to monitor these patients. So I think oral drugs will be out, and insulin should be the standard form of care. And what type of insulin will we use? I think the experts will make their comment on that, because what I understand is short-acting insulin as and when required. Okay, while the glucose is monitored very closely.
Okay, so I would like the experts to comment on how tight the control should be. Should we have sugar less than 140, or is it okay to have it between 140 and 180?
So generally, a person who is on OHA and well controlled, you can go slow on the diabetic control. You have to monitor, but there is no urgency to make it to very normal levels, because these patients are at a higher risk of hyperglycemia. You should prevent hyperglycemia also. You should also attend hyperglycemia as well as hyperglycemia. So it should not be very strict. So a person who is very well controlled with OHA, probably can be little slow. But a person who was very difficult to control and has got the multi-organ dysfunction, kidney disease, etc., you don't want to create more problems. So monitoring is important. And if it goes to the hyper side, I think we have to use the short-acting insulin. I think I invite the opinion of our two expert panelists also in this scenario.
Vipin, I would like your comment on this. Now, very pointed question. One is,
Jian, you are not audible.
am I muted?
Yeah, now it's okay.
Okay. Vipin, I would like your comment on this very pointed question. One is, you did mention to us that the control of blood sugars need not be very tight. You can afford to be a bit loose as far as control of blood sugars are concerned, particularly in child B or child C cirrhosis. But what would be your choice of insulin? Traditionally, we have been using the so-called human actropid or whatever it is. What would be your choice of insulin for control? Number one. Number two, once you have controlled or once the patient is out of the crisis, when do you decide that this patient can go back to the oral drugs, or is it that once on insulin, always on insulin?
Yes, sir. Regarding the first part of the question, when the patient is admitted with a chronic liver disease decompensation in the ward, not in ICU, so generally we will keep the target between anything between like 100 to 180 or 100 to 200, because we are having other concerns like whether the patient is eating well, whether the patient is having put on rice tube, whether the patient is having washout time for the previous OHS the patient was taking, or long-acting insulin the patient was taking. So generally we'll stop everything, even if the patient is on like 40 to 50 units of insulin or 100 units of insulin, you stop everything along with OHA. Then you can give a small correction doses for the first day. This correction boluses, that means the insulin that you should use is a rapid-acting insulin. If possible, it should be used after the meal, because we are having ultra fast-acting insulins now, like 5-ASP or something, which can be even taken after the meal. So depending upon the patient's appetite as well as desire to eat and the amount of food he eat and the blood sugar at that time, you can give the correction boluses for the first 24 hours. So then we will know what is the total daily requirement for that day. We don't mind to have the blood glucose between 100 to 200. So the next day we will calculate the total daily dose the patient was requiring, and we will add a small dose of basal insulin at that scenario, like maybe start with a 6 unit or 8 unit and continue with our ultra short acting insulin maybe after the meal. Then you start gradually build up. By the time of discharge, the patient will be having must have reached a total daily dose.
Yeah.
Total daily dose of.
Has it any stuffing inside?
Who's this? Prakash, could you just help me by?
Yeah, I do.
Yes.
Okay.
So by the time of discharge, he must be receiving around 50% of what he was taking before admission. So generally, we tend to discharge the patient on insulin, not on OHA, and reassess him shortly after the first review in the OPD. Then restart him on OHA once patient's appetite is all right, liver functions are better, creatinine is normal, and he's not having any gastric upset. So the answer is short-acting or ultra-short-acting insulin to control the blood glucose to start with, then go for the basal bolus regime. Then target is between 100 to 180 milligram per deciliter. Should not produce hypoglycemia.
A patient who was on metformin before and had to be switched over to insulin for control. Now you decide to go back to oral drugs. Would you prefer to go back to metformin once again, or would you be choosing the newer molecules?
Sir, in terms of efficacy as well as benefit, metformin is again the first choice for me, because you can see the other molecule that we are mentioning is the DPP-4 inhibitor, which can be safely given like a linagliptin. But if you can see the efficacy of linagliptin 5 milligram versus 1 gram of metformin, clinical practice, metformin 1 gram is superior in terms of glycemic control. But the problem with metformin is definitely patient can have gastric upset, nausea. Sometimes it can add on to the sarcopenia as well as the malnutrition patient is having. So we may not be able to restart on metformin even if you want. In such scenarios, we can go for a DPP-4 inhibitor, which is having a positive effect on the sarcopenia aspect, and it will not have any effect on the malnutrition aspect. So this is my comment on that, sir.
So does metformin produce sarcopenia? It reduces the appetite, but does it produce sarcopenia?
Regarding to sarcopenia and metformin, this is having plus and minus effects, sir, but it is not having any positive effect on the improvement of muscle mass in a patient who is having sarcopenia. But on the other hand, a DPP-4 inhibitor like a linagliptin is having a positive effect on the sarcopenia aspect, sir.
So I think it's a very interesting point that you made, that metformin would probably be better than the DPP-4 inhibitors, and you would probably prefer to go in for metformin. Arun, do you share the same view, or do you have something else to say?
No, I fully agree with that.
That is something
what
that
he
is
would do.
used.
Yeah, what he would agree. I just wanted to pick up on the previous point and just wanted to have a bit more clarity. Now, we said we would prefer sugars between, say, 100 to 200, and Vipin and I agree with that. I think one of the problems we see on the ward is, are we talking about pre-meal glucose or are we talking about post-meal glucose? And we know that the CLD patients, the problem is actually with the postprandial, the higher way. So what most often we see is when we go to the ward, we see that there are 3 pre-meals, which are all 200. And they say, sorry, this is 200, what's the problem? But then this 200, if they had actually done a postprandial, would be 360 or 400, you know. And then suddenly somebody does a postprandial, and then we get a call in the middle of the night or something saying, this is 460, what are you going to do about it now? But maybe the patient had 460 all the time when the patient was eating or post-eating. I mean. So this is always a big problem on the ward. I never know whether to overdo the sugars in the first 24 hours. I would prefer that in unstable patients I would prefer a 6-point or a 7-point profile in terms of pre-meal into 3, post-meal into 2 to 3. The reason being that post-dinner also we need to know to make sure that they're not going into hypos, because otherwise if you keep on increasing, because you see very often you see situations where a poor junior is called at middle of the night, at 10, not 10 o'clock, maybe 8 o'clock in the night, and asked, now the sugar is 350, what should we do? And you would say, okay, give 20 units, and this patient goes into hypo.
Okay.
So it's a very difficult thing unless we have a 24-hour 6-point profile. It is sometimes difficult. I know it is not practically easy in all patients, but I think you need to get a balance there.
Krishnadas, you wanted to make a point.
Yeah, Arun, is the problem basically of the FPS? Because we know that glycogen levels in the liver is very low if the patient is having decompensated chronic liver disease. So the FBS is low. But does this reflect on the postprandial, pre-dinner, and post-dinner? Because during these times, the patient is taking food, so the glycogen will be replenished. So these patients may not be that prone to have hypoglycemia. So it is only the FBS that is low, but the other values will correspond to the actual blood levels of glucose in this patient.
So the typical profile you would see is, you are absolutely right, fasting sugars will be low. But then and what happens because of that is, because of the sliding scale, this is where I am against sliding scale, because the FBS is 90 or 100, the insulin is omitted in the morning. And then what you see is 10 o'clock, the sugar is 350 or 400 because they have had a breakfast. And automatically what happens is the sugars go down because there's no insulin given. So it is more to do with the insulin that is given, Krishnadas, rather than, so I'm not saying that postprandially people will go into hypo, they won't. In fact, the sugars will be higher, but the insulin that is given at that time is wrong, because fasting is fine, they are not giving insulin. Then the sugars go up, and then you give a big dose, and then the sugars again go down, then you don't give insulin in the afternoon. So we are catching up rather than actually proactively managing it. This is what happens on the wards, and it's, unless we have a full profile, it's sometimes difficult.
So
but typically
postprandial inhibitors have a role?
Yeah, they have a role in stable patients. In patients who are in hospital, definitely insulin would be preferred. But in stable patients, certainly worth trying. It may not work in all patients. If it works well and good, if it's not, then insulin.
So Arun, can we assume or imply from your discussion that for patients who are admitted, we should have pre and post meal blood sugar monitoring?
Maybe for the first 24 hours. You have caught me out there, because the patient will probably hit us when we visit his room after that. If you do 6 or 7 pricks along with all the other needles that he's getting. He's going to. So I think we have to, the difficulties, yes, I would like to see a 24-hour profile at least, and then make a judgment, because otherwise it's very difficult to make a, because you start them on 3 times actrapid, or and then you don't know whether to increase or decrease, because you don't know what actually the effect, what effect that actrapid has had, actrapid or novorapid or Fiasp, whichever, the pre-meal insulin or that you're given, what effect has it had on the postprandial? Because that's what matters, isn't it, ultimately? So unless we see that profile, it is difficult. But this is a difficult call, because when patients are in the ward for 2 weeks, 3 weeks, are you going to do 6 times a day? No, I think that is impractical. So we have to pick and choose those patients.
Okay, quickly going on to the next question. I think we've had a lot of discussion, but Vipin, I will just ask you to tell us, in a well-compensated liver disease, is there any oral anti-diabetic drug you will not recommend?
Yes.
In well-compensated, child A.
Okay, sir. Regarding the compensated liver disease, my preference is like metformin, DPP-4 inhibitor, followed by SGLT2 inhibitor, or GLP-1 receptor agonist. These are the 4 important things that I would like to consider. I would like to avoid a pioglitazone because of the weight gain as well as edema property. And if possible, I would like to avoid a sulfonylurea because of the hypoglycemia tendency.
Okay. And when you go on to decompensated, now child B, child C, which are the things that you would, let's pick up child B first, child B.
Child B, if the patient is already on metformin, I would like to continue on that. Or if I am starting on metformin, I'll continue with 500 or 1000 milligram maximum per day. But definitely my first choice is a DPP-4 inhibitor in a decompensated liver disease rather than a metformin. Decompensated.
Child C.
Child C, if possible, avoid all OHAs, but I use linagliptin or DPP-4 inhibitor even in child C patients, because with insulin alone, it was very difficult to control blood sugars in child C, many of the patients who are on basal bolus.
Wonderful, wonderful.
I don't really use the Vildagliptin because there's a concern about Vildagliptin.
Ramesh?
Yeah.
Sorry.
So, who's Verghese Thomas raised a question on Vildagliptin. Will you use it in child C because there's a concern?
Child B also.
Child B also. Child B also.
Yeah.
So I mean, I think Vipin has kind of said, yes, I think Vilda, there has been a concern all along. Although I have to we do use it. Probably we shouldn't be, but because the studies haven't. It's difficult. There is no clear-cut evidence to say that they cause harm, but we have to extrapolate whatever evidence we have. So as I would stick with what Vipin is saying and use linagliptin when it's possible. The cost is the issue many times. I think that is why we kind of cut corners, which is not right. Take the case of teneligliptin, for example, which is probably the one that we all use quite a lot. The evidence is pretty sketchy when it comes to it, very, very scratchy evidence around it in all liver disease. But they seem to be safe. But again, the evidence is not there. Vipin, am I right? Or
yes, sir. For teneligliptin use in chronic liver disease, there is no data. Because nobody has
used all the time. So this is where cost consideration comes into the picture. But I think in a forum like this, you can only say it is linagliptin that we should be using, because that is where the evidence is.
Linagliptin is more expensive.
Yeah, it's about.
Okay, Krishnadas, you want to make a point?
I think in childhood C patients, we are not supposed to use any DPP-4 inhibitor or SGLT2 inhibitors, because it has to be avoided in childhood C.
Right.
And it should be used with caution in childhood B patients. And one of the major concerns with SGLT2 inhibitors is urinary infection, urinary tract infection. You have a childhood B patient, you get an urinary infection, most probably the patient will decompensate and maybe even die. So you should, SGLT2 inhibitor should be used with that extreme caution in patients with childhood class B. And one thing we should always ask is whether the patient is having prostatic symptoms. Many of these patients will be having a benign prostatic hypertrophy. There will be urinary retention. Some amount of residual urine will be there. This is a culture medium for bacteria. So you should not use SGLT2. I mean, it may not be prudent to use SGLT2 inhibitors in patients with BPH. And regarding sulfonylureas, I think one thing that didn't come into the discussion was that short-acting sulfonylurea should be used and long-acting should be avoided. So glimepiride,
Yes,
which
sir.
is the most favorite sulfonylurea, should be avoided because it's quite a long-acting one. I think the short-acting may be glyburide and glycoside.
Glipizide, sir. Glipizide. Short-acting.
Vipin did mention about this preference of short-acting sulfonylureas over the
Yes.
long-acting sulfonylureas.
Right.
So
GLP-1 receptor agonist should be avoided in childhood B as well as in childhood C.
See.
So
Right.
what is the ideal drug for a decompensated with
I think metformin can be
difficult to
used in
control
childhood B and even early childhood class C patients. If they do not have any symptom, any sign of sepsis, no renal dysfunction, no cardiac dysfunction, you can safely use metformin around 1 gram per day. Insulin, especially the newer insulins, can be used.
Krishadas, I put this prescription in front of you. This is something that I think we have been using such prescriptions for a long, long time. How would you tinker with this prescription in a patient who's got well compensated cirrhosis?
Yeah.
So you have
patient
mentioned the first
patient-
molecule should not be used.
No, the patient, it is said that there is no hypoglycemic episodes. And his hemoglobin A1C is 6.2. But actually, we don't know whether this hemoglobin A1C is correct. Because even in compensated cirrhosis, there may be a reduced RBC life. And hemoglobin A1C depends on anemia. That is the amount of RBCs as well as on the lifespan of the RBCs. So this may be falsely low and the patient may actually be having a higher hemoglobin A1C. So we will be more comfortable with a few postprandial blood sugar values. And we would like to know the LFT, especially transaminases, because this patient is on pioglitazone. Even though it is a pediatric dose of pioglitazone should not be used if the ALT levels are more than 3 times the upper limit of normal. And also, we would like to know if the patient has had recent weight gain, which could be a manifestation of edema, or the patient is having fetal edema, in which case pioglitazone should be stopped. Voglibo is fine. Yeah, in decompensated disease, the Voglibo is the main side effect would be abdominal bloating, and especially if the patient is having ascites, it will be very disconcerting to him if the patient develops abdominal bloating. Otherwise, Voglibo is a very good drug in compensated as well as decompensated disease. Dionin, again, it is a long-acting because the metabolites that are produced from glibenclamide are also active, and so it should be considered as a long-acting drug. We should reduce the dose of dionin. And pioglitazone, if there is an edema, if there is any weight gain, we should stop it. And then the drugs are DPP-4 inhibitors because he has got compensated disease. You increase the metformin to 1.5 grams, and SGLT2, as I mentioned before, if it does not have any prostatic involvement, then SGLT2 inhibitor should also be used.
So great. Arun, anything to add to what Krishadas has said?
I think he should have been an endocrinologist. I don't know why he's a gastroenterologist. The Pyoglit, Krishna's, Pyoglit 7.5. Is there any evidence anywhere around 7.5? Of course, there is a preparation available,
It's 15 milligrams.
There is no evidence around it, which you kind of mentioned. You did touch upon that it's a pediatric.
It's a pediatric dose. I don't know whether it works at all.
Yeah. So you're absolutely right. You have hit the nail on its head.
But Arun, we have seen patients on pioglitazone 7.5 milligram, because many of these patients are on pioglitazone 7.5 milligram, even though it is a homeopathic dose. They develop leg edemas.
Yeah. Side effects.
So I think pioglitazone should be avoided.
Yeah. So they probably won't give you much of glucose control, but they will give you side effects, and they probably don't give you much liver benefits either, isn't it? So
great. Okay. Now we'll switch. We'll skip this because I think Arun, you would agree that we have discussed a lot on this. But my next question is to Varghese Thomas. Now, a patient who has diabetes presents with an acute viral hepatitis. Now, he is a diabetic who's been well controlled with oral hypoglycemics, and metformin is also there in that prescription. Varghese, what would you do? A patient needs admission. He's got admitted. Fortunately, there are no complications of acute viral hepatitis, but we need to decide how best to control his diabetes. Would you continue
Okay.
with the drugs or would you change?
A person with acute viral hepatitis has a lot of problems due to nausea, vomiting, and possibility of not eating well, etc. So, therefore, even though he has not gone into very severe hepatitis, still there is a risk of hypoglycemia. So, I would rather stop the oral anti-diabetic drug for a while and keep him under monitoring. There is no urgency to continue the same dose of oral hypoglycemic. It's a well-controlled patient. So, and once he is able to eat well, then probably at that point of time when the target is about 200, then we may think of adding an anti-diabetic drug depending on, suppose that the liver severity, if you have got a very severe liver disease, its bilirubin is very high, it will be safe not to use most of these oral drugs at all. And it will be safe to use, again, as I told earlier, in acute situation, it is always safe to use insulin, which is fast acting. And then depending upon the situation, you add on other basal insulin also. I think the issue was covered in a slightly different way earlier by Dr. Vipin also. So there is no urgency to continue. You keep the patient under monitoring, and if situation demands, we use short-acting, fast-acting insulin.
Very good. Is the risk of hypoglycemia higher in a patient who has got an acute hepatitis?
Acute hepatitis. No,
Yeah.
acute hepatitis depends. It depends. See, many of the patients stop eating many things because of the severe nausea and the lot of restriction on the part of the community on the patient or the relatives on the patient not to eat food properly, and patient will be literally starving. And probably in many hospitals, I have found he is just living on the IV fluid which is given to the patient, like 1 or 2 units of dextrose or dextrosaline they are getting. They are practically starving, and most of our people they will be in ketosis also, starvation ketosis. So in such a situation, we don't require diabetic control at all at that point of time.
I would
So
like to change the clinical scenario a little bit. This patient has got he's a diabetic. He presents with acute hepatitis. Is uncomplicated. You don't need to admit him. You're going to send him back home. How do you then control, or what do you advise as far as the anti-diabetics are concerned?
Even well-controlled diabetic patient coming with acute hepatitis, which is not so severe, is sent home. Still, I would say stop OHA for the time being. Stop OHA for the time being, and monitor the glucose.
Monitor at home. That's
monitor
what
at home.
Dr.
Yeah,
Vipin
and then tell
said
him
about
that if it goes above certain
self-monitor.
values, will contact us. And then, depending upon the situation, we'll give a safe oral hypoglycemic drug.
Dr. Vipin, anything to be added before we go on to the next question?
Nothing more, sir. It's a wise decision.
Wise decision. Very good. Any interactions of drug used in liver disease which one should be worried or aware of in treatment of diabetes, which we should be worried about, gastroenterologists?
Generally, in clinical practice, actually, we don't have such significant interactions other than when you're using steroids for autoimmune hepatitis or when the patient is having hepatitis C on treatment, or a post-transplant patient with diabetes mellitus who are on immunosuppressants as well as steroids. Otherwise, generally, we don't have any clinically meaningful drug interactions between an OHA and the usual drug which is prescribed for the management of a liver disease. But definitely we have to monitor the eGFR depending upon the creatinine value, and definitely the liver function will be monitored for such a patient, sir. So this is my comment, sir.
Jen, before Dr.
Yes.
Vipin stops, can I ask this question? Most
Yes.
of our patients in gastroenterology are put on steroids and develop a steroid-induced diabetes for the first time, or we will aggravate a pre-existing diabetes by giving steroids.
Right,
Is there a change in the management at that point of time? Because this is one question which every gastroenterologist faces.
Right, sir. When on top of a chronic liver disease or an acute liver disease, when we are adding a steroid, the glycemic pattern changes for that patient. The patient will be having an increased postprandial blood glucose, pre-lunch as well as post-lunch and pre-dinner blood glucose, and it gradually settles down depending upon the steroid that we use. Like if you're using an prednisolone or type of an agent, it will be having a more effect on the morning, and the blood glucose will be maximum towards the evening, then it gradually settles down. On the other hand, if you're using a dexamethasone, throughout the day, the blood glucose values will be high because the duration of action of dexamethasone is on the higher side. So like in a patient who is on prednisolone, then we can definitely consider an intermediate acting insulin, a premix insulin, 1 time per day, like in the morning, which can be added to the pre-existing treatment regime to control the blood glucose. Because there's a steroid-induced hyperglycemia is basically, it will last for around 12 to 16 hours, then it gradually settles down by the next day morning.
Okay. Krishnadas, this is a situation where you have a patient with chronic liver disease, acute kidney injury. Now, what would be the choice of anti-diabetic agents? All of them go on insulin, or would there be?
Thing is, if you look at there is no, I couldn't find any data on AKI, but what I think is we can extrapolate it from CKD, because the American Diabetic Association 2021 guidelines, metformins are contraindicated. You should withdraw metformin, especially the patient with AKI HRS will be having decompensated liver disease. So drugs that cannot be used in decompensated liver disease cannot be used in such patients. So metformin should be withdrawn. SGLT2 inhibitors, again, there is a risk of UTI, should be withdrawn. GLP-1 receptor agonist should be avoided in child BC. So there is no role for such drugs. DPP-4 inhibitors, again, if it is a child C disease, you cannot use it. Child B, even though renal dose adjustments are required for sitagliptin, sexagliptin, and alogliptin, and there is no dose adjustment required for linagliptin, I don't think that even DPP-4 inhibitor should be used in such patients if the patient is presenting with AKI. Among sulfonylureas, only glyphosate can be used as far as renal dysfunction is concerned. But again, sulfonylureas is not a good drug to use in patients with decompensated disease. Thiazole and diones, we don't even need to look at that. So only thing that is left is insulin and the alpha glucosidase inhibitors. So you may have to limit yourself to use of insulin in such patients till the AKI resolves.
So Arun, the answer to this question would be insulin and only insulin. Is it? Am I right?
Yep. I think AKI, I think that would be the safest bet, isn't it? Largely, it's not only about the side effects, it is also the unpredictability of these agents. Say sulfonylurea, Krishnas was saying, could be used. Yes, perhaps could be. But you sometimes don't know then when it's going to cause hypos, because they are going to last in your system much longer. So it's a predictability of insulin that is beautiful when you look at it that way, than the OHS and their side effects on specific this thing. So you just can't predict which way the sugars are going with OHS, and the effect might last for much longer.
Okay, we have discussed this.
Yeah. Among the insulins, do you have any preference in such situation?
I would still go by the profile, Prakash. So if we find, so this is where a profile helps. We would, as far as possible, avoid a basal at that point, because in acute AKI, certainly you don't really need basal, because even your actrapid is going to act like a basal, isn't it? Because it's going to remain in the system, it's not going anywhere. So their action changes, and they all kind of even the short acting insulin becomes a longer acting insulin. So I would prefer to keep with the shorter acting insulins, and only in patients where you feel that a basal should be added, you would. For most patients, you can manage with short-acting insulins. And that gives us a chance also to either increase or decrease the dose if the renal function is going off, or if something else, if the patient gets unstable.
This CLD and CKD, I think it's probably the same thing that we discussed in the last question. I don't think it's going to be any different.
Yeah, it's pretty much same as, so my only point to add would be, of course, once the AKI resolves, some of these drugs can come back, and it depends on what the EGFR is in terms of getting metformin in there. You have to be very careful. I wouldn't want to say both in the same breath, at least for our junior staff and all that. But those who understand it, certainly there could be a role, as Krishnas was saying earlier, in a small proportion, a small dose of metformin might have a role. Other drugs, as we have rightly said, I mean, SGLT2 is probably now being used more and more because of its renal benefits. But I don't think we have enough evidence as to this use in the long term of SGLT2 in people who have advancing renal failure. Nephrologists seem to be very comfortable now when they're using it in people with creatines of 3, 4 and all that. So, but I just feel that there is not enough evidence, because we don't know when these patients are going to get unstable and what's going to happen, because the evidence is just not out there as far as I know. Again, Vipin can correct me if I'm wrong.
Vipin, any comments from you before we go on to the last question? And
No,
then
sir,
the
actually,
chat box.
because SGLT2 inhibitors, because as I said, because of the non-diabetic indications, because we have DAPA CKD trial, DAPA heart failure trial, etc., where the patients were not having diabetes mellitus still were getting benefit of dapagliflozin in terms of heart failure as well as kidney disease progression. So based on that data, many of the people, many of the practicing doctors are prescribing dapagliflozin inadvertently. But it's definitely you have to see the eGFR criteria. Even with DAPA CKD trial, the eGFR criteria should not be used less than 25, precisely 30. We can say clinical practice 30.
And while we are on SGLT2 inhibitors, can I ask Dr. Arun, why is there so much of ASCVD improvement as well as heart failure improvement with SGLT2 inhibitors, even though these receptors are said to be in the apical membrane of the kidneys? Are they present in the heart also? So is it just a factor of weight loss and control of diabetes?
It is present in the heart and vasculature as well. So the effects are direct effects as well. The thing is that the easiest answer to that is nobody knows the exact mechanisms. Okay. So because of which there have been so many mechanisms that have been, the vascular effect has been touted as one of the most important thing. Vascular effect everywhere, and also the cardiac. I mean, the heart itself per se doesn't have the receptor, but there is benefits to be had by the SGLT2 effects.
Yeah. I would prefer that easy answer. We don't know.
We don't, yeah, I think the jury is still out in terms of what exactly the mechanism is, but there seems to be multiple. It's just not the simplistic mechanisms that we know, which is the glycosuria and the weight loss and the improvement in BP and the not much of improvement in lipids, but improvement in glucose. It's beyond that, because you know that the benefits in terms of cardiac benefits, especially in heart failure, actually starts within less than a month of you starting these medications. So clearly it is not due to that alone. So there is some effect that these drugs directly have in terms of reduction of heart failure, hospitalization, something like a diuretic would have. You know, I don't think it's again just simplistic diuretic effect either.
Is it because of the loss of water?
That is one factor, but that alone is not the factor, because we know they don't lose that, you know, they don't lose, the diuretic effect is not huge, isn't it? There is some diuretic effect, but even diuretics don't give you that sort of benefits in terms of hospitalization for heart failure. So the effect that benefit you get with SGLT2 is in terms of hospitalization for heart failure is over and above even diuretics. So there seems to be some direct cardiac effects, benefits, that cardiovascular benefits.
I've skipped that autoimmune hepatitis because I think it is essentially about steroids, and that has already been discussed. The last question is, I think it was raised by Dr. Rajesh in the chat box. Hepatogenous diabetes, how is it different from the conventional or the usual diabetes? Krishnadas.
Yeah, we all know that diabetes and liver is very much interrelated. Not only does diabetes result in chronic liver disease through NAFLD, the liver disease produces diabetes. Liver disease per se produces insulin resistance and produces a state of diabetes. So there are a few points to differentiate between these two forms. That is type 2 diabetes mellitus in a patient with liver disease, going on to liver disease, and a patient with liver disease who also has diabetes, that is known as hepatogenous diabetes. The onset in the first case would be much before the onset of chronic liver disease, whereas hepatogenous diabetes usually occurs after the onset of chronic liver disease. The risk factors of diabetes mellitus like obesity, family history of diabetes in patients with disease, whereas chronic patients with hepatogenous diabetes. if you look at the serum insulin HOMA-IR, it is lesser in patients with diabetes and liver disease as compared to patients with hepatogenous diabetes. So hepatogenous diabetes patients basically have more of insulin resistance. And diabetes-related complications, which is a function basically of the duration of diabetes, is more frequent with diabetes and liver disease, and is less frequent in patients with hepatogenous diabetes, whereas liver-related complications are more in hepatogenous diabetes. Hypoglycemia, there is a higher risk in hepatogenous diabetes because these patients may be having more severe liver disease. And after liver transplantation, usually if you have a patient with diabetes mellitus and liver disease who is transplanted, there is usually persistence of diabetes. Whereas there is reversal of diabetes mellitus and hepatogenous diabetes in almost 60-70%. So these are the basic differences between hepatogenous diabetes and diabetes with liver disease.
But does management pose a problem?
I think management is basically the same. And there is a very good article on hepatogenous diabetes by Kumar et al. Published in the Indian Journal of Endocrinology Metabolism in 2018. I think everyone should read that.
Good. Anthony, if you could just pick up questions from the chat box and direct them to our panelists. Anthony?
I think Anthony
you
is
can,
busy with
Prakash.
something. I just take it up.
Yeah.
So there was one question about the issue of beta blockers in chronic liver disease, because which is used very frequently. And do you have any concern during management because of effect on hypoglycemia or recovery from that? Dr. Bipin or Arun can take it up.
Yes, sir. Because when we say diabetes mellitus management, beta blockers are not a diabetes friendly drug, because we know that when we use beta blockers, there are two things to happen. One is it can worsen the blood glucose control in patients with who are on diabetes. And the second, the hypoglycemia, when the sympathetic activity when the patient is getting hypoglycemia will be masked. So these are the two effects. But we know that when we use beta blockers in patients with chronic liver disease, it is a necessity for the chronic liver disease to manage the portal hypertension by using a beta blocker. So generally, as long as the patient is requiring this molecule, we don't mind considering a beta blocker in a patient diabetes and chronic liver disease. But we know that liver disease per se is having a higher risk for hypoglycemia. So we should be worrying regarding hypoglycemia risk, because we know that hepatic stores of glucose are not good. So when the patient is getting hypoglycemia, it tends to be more severe when the patient is on beta blocker. That's the only one main concern that we are having when we are using a beta blocker, especially a non-selective beta blocker in diabetes and CLD.
We are using more and more of carvedilol nowadays.
Yes.
So is it different from propranolol?
Definitely,
as far as
sir.
diabetes is concerned and control of diabetes is controlled?
Propranolol is a non-selective beta blocker. So it is having basically effect on the sympathetic system as well. And on the other hand, carvedilol is mainly cardioselective. So it is having less effect on the diabetes part as well as the sympathetic part, sir.
So should we prefer carvedilol over propranolol in this sort of situation?
It's up to you, sir, because whichever drug gives you the better effect, you can use that.
Yeah. So there is no difference as far as diabetes is concerned?
Sir? Yeah, regarding the diabetes.
There is no difference between these two drugs?
No, diabetes friendly is carvedilol, no doubt.
Okay, thank you.
Diabetes friendly is carvedilol. But I think actually for liver disease, which is the best one in terms of efficacy.
Nowadays, carvedilol may be more acceptable.
Is your experience, have you had problems with beta blockers? Have you had problems with propranolol and blood sugars?
Is it question to me?
Yeah.
Yeah, very occasionally I have seen, especially when patients are put on divanil and all, they come with hypoglycemia. I think, but most of the patients have been changed to metformin. Then I don't find much of a problem. But older patients with libintamide and propranolol had a couple of issues earlier. But I have changed all those patients from libintamide completely.
Over to you, Prakash.
Yeah, we'll go to the next question. Dr. Sudhir has a question to Arun. Anything on newer insulin sensitizers, especially insulin resistance in obesity, other than metformin and thiazolidine?
Insulin sensitizers.
Yeah, that's a,
Don't think so. I don't think we have any other. Sorry, the question is are there any new other
yeah,
newer
anything
insulin
new.
sensitizers?
Yeah, that's it.
Not necessarily. I mean, as a sensitizer per se, the SGLT2 perhaps has got some effects in terms of those benefits. GLP-1 analogs might also have. So they all have some effect on the insulin sensitivity, and which is one of the reasons why we think they all have cardiac benefits as well. You know that the studies have very clearly shown GLP-1 analogs have got significant cardiac benefits, or at least good cardiac benefit in SGLT2. So if you can, we don't call them necessarily insulin sensitizers, but they do have as their myriads of actions insulin sensitive improvement in insulin sensitivity as well. So those are still the ones. So we don't have, if you're looking at a newer molecule which is an improvement on the glitazone or metformin, unfortunately, as far as I know, there is nothing on the pipeline at the moment, at least not
Okay.
in the near future.
Thank you. So Dr. Tony wants to know what is the mechanism behind the propensity of vildagliptin to cause hepatitis and gallstone disease, calculus polycystitis, spontaneous GB perforation events. Anyone wants to take it up?
I should have taken it, but I'm not sure. So if you have,
Yes, sir.
I actually,
No, sir. Previously, when vildagliptin came to the market, there was a caution regarding the use of vildagliptin in patients who are having slightly impaired liver function. So the usage of vildagliptin itself can damage the liver and etc. and etc. But when we see the data 10 years or 20 years down the line of using vildagliptin, there is no alarming risk of any of these complications when we use in clinical practice, and real world evidence as well as subsequent follow-up studies, none of them have shown that vildagliptin usage is alarming to the liver or produces any of such sort of complications. Like any other DPP-4 inhibitor, vildagliptin is also having the class effect like a DPP-4 inhibition. And other than that, it is not a specific molecule to produce any of these side effects. This is by best of my knowledge, what I have read regarding vildagliptin.
But in spite of that, vildagliptin is not recommended in liver disease.
Right.
I think it's because of the few case reports of hepatitis-like picture. I think such a minuscule number of cases were reported in the literature, and ever since vildagliptin, I think, is not favored drug. That's what I think.
Excellent.
but there are, sorry, there are a lot of post-marketing data, isn't it, that has come out on vildagliptin, huge numbers. There's this big data now, isn't it, with all these retrospective studies. They really don't show any increased problems.
Yeah, that's what I feel.
Yeah.
Even if you get 1 or 2 case reports, FDA put a black box warning for many of these drugs. Even they haven't removed even for sitagliptin, even for canagliflozin. There are black box warning for many of these drugs, even though there is contrary data which is
phase
available.
4 studies are often manipulated. So how can we believe that?
Right.
Right. So we'll move on to the next. Dr. Shine asks whether SGLT2 inhibitors improve ascites in chronic liver disease because of increased natriuresis. Do you have any such data, or Dr. Krishnadas, Dr. Varghese Thomas?
I have no idea.
Does it produce natriuresis or glucosuria?
In natriuresis as well. It does cause theoretically natriuresis, but I haven't seen any data. If you guys have seen, maybe.
Anyway, we haven't found anything great. I mean, those patients on ascites, whether they do well. Anyway, we need to check it on that. But
there is an problem with ascites patients usually have child C disease, and it is contraindicated in child C disease.
Yeah, actually, there is an article in hepatology. Ascites improvement with SGLT2.
Okay.
Okay, Smith. Yeah, we will check on that. I have not actually seen that. That'd be good.
So, regarding acarbose, what about its use in to control postprandial surge? I think we have talked about it.
I think acarbose can also produce hyperammonemia. I think it should be avoided in patients with decompensated chronic liver disease, ascites, etc. No?
So better to
maybe
avoid.
child be okay, but child C, I think better avoid it. And as Krishna rightly said, in the patient with already ascites with a lot of bloating and all, it will be really discomforting to the patient.
So this is another question from Dr. Tony about another molecule which we didn't discuss at all. That is about saroglitazar, whether it has got any anything to do in pre-diabetes patients, especially patients with non-alcoholic fatty liver disease and diabetes. Anything?
I think Krishna has asked out original data. He will answer.
I think
has-
we use saroglitazar quite liberally. I think now the DCGI has given approval for NAFLD with comorbidities as well as for diabetic hyperglycemia and diabetes hypertriglyceridemia. So if you have a patient with hypertriglyceridemia, definitely it does wonders. We have found that even there is almost a 25 to 30% reduction in the fibrosis as measured by VCT when you give saroglitazar for 1 year. So saroglitazar is quite useful, but it is a weak hypoglycemic agent.
So
Maybe the
indirectly,
HbA1c may come down by maybe 0.6 to 0.8. But it's very effective in triglyceride levels as well as in reducing fibrosis in patients with NAFLD and fibrosis.
so indirectly that should help the sugars as well, isn't it? In diabetes as well, isn't it?
It is a bit weak.
But we don't clinically see much of an improvement in the glycemic parameter alone. But I accept your point. But we would have expected a bit more of glucose
Basically a
improvement.
triglyceride.
Yeah.
It is a PPR alpha plus gamma agonist. And
Should we
there's
use
a
a
mixture of
statin
effects.
also?
Pardon?
Should we use a statin also?
Yeah, depends on that depends on the LDL levels. This is basically for triglycerides. Reduces triglycerides quite dramatically. It boosts up the HDL a bit, but does not do much for the LDL. If you have a high LDL, then atorvastatin will have to be added.
Are you planning any clinical studies, Krishnas? Is there any?
Already done
We
it.
have
Oh,
data
yes, done it.
on
Oh, this
more
is.
than
Oh, you
100
published?
to 150 patients.
Okay. Have you published it?
No, not yet. Because the corona threw a spanner in the works. So many of the patients were lost to follow up. Otherwise, we would have definitely had more patients.
Right. I think it is getting late. GN, should we conclude the session? Because
Yeah, I think we had a great discussion. In fact, so many messages. But I think I'm really excited about the semaglutide oral preparation. Arun, what do you think would be the cost? Your guess?
I think they will probably keep it same as the injections. The injection, the once a week injection is 2,000 rupees. So I think this will be one of those tablets which is going to cost a lot of money. So my bet is they are going to keep it in and around 2,000 rupees one tablet. So 1 month will be 8,000, which when you look at it that way is not too bad because a lot of insulins would cost that much. So many medicines cost that much. But people will look at this one tiny tablet and think 2,000 rupees, is it worth it? I think that is going to be the challenge.
This tablet is also weekly?
Once weekly. And GN, are you interested to see what that snack is? I'll just not snack. I'm not talking about the nighttime snack.
SNAC. Okay.
If you look at Google,
as a part, yeah, I'll put
Yes,
it as a parting gift for you. This is what it is. Now, your gastroenterologist guys can figure out what all this means.
SNAC as a parting gift sounds quite exciting.
Yeah. Right. So this is what it is. For a gastroenterologist, I'm sure this will be very appetizing or appealing. So SNAC is a sodium N-hydroxy benzoyl amino caprylate.
Yeah.
And it seems to have some action on the gut epithelium. As you can see here, I don't need to read it out all, isn't it? If you can see it.
Yeah.
So there is a local the pH seems to be increased, and then in a way it is protecting conversion from pepsinogen to pepsin, and that way it is facilitating transcellular movement of semaglutide. That is what is touted as a mechanism. I don't know. This all seems quite a lot to me.
Theoretically speaking, you can add it. You can also use it for the sublingual preparations.
Sir, can I add?
Yeah.
So, because actually when I read through this one, these are one peptide molecules given along with this snack. So both are remaining in one compound, like a co-formulation, not both of which are not attached. So it all depends upon the local property of this molecule. When they come to the stomach should be empty. So it should be taken in the empty stomach. And you should not eat anything for the next 30 minutes because it will affect the efficacy. So when it comes to the stomach and contact with the mucosa, it will increase the local pH. And both the molecules are separate then. Then the peptide molecule will go through the transcellular route and get absorbed. And immediately you can see the concentration peaking in the blood. So this is a local
So the
mechanism.
question, Vipin, is, can
Yes,
snack
sir.
be used with insulin?
Novo tried the snack molecule with Novo tried this molecule with insulin as well. The original research started with insulin, but it was not successful. But because of some molecular peculiarity of semaglutide, it worked well. So now they have captured this snack patent for them, Novo. So Novo will be investing more on this one, or in investigating this molecule in other preparations as well.
So this seems to be something like a vehicle, isn't it? This
right,
one is
vehicle, right,
and kind of taking it there.
Right.
Okay, so I think we'll have to close the discussion now. I would like to place on record our gratitude on behalf of ISG Kerala chapter to Arun as well as Vipin for having spent time with us. It was wonderful because so many interesting concepts, so much of new information that we've been able to assimilate. Thanks a lot for all your efforts. To Varghese and Krishnadas, thanks a lot for your inputs and having agreed to be part of the panel. Prakash, whose idea it was initially to start off this sort of a webinar. And Prakash, thank you very much for the opportunity given to me. And on behalf of the panel, let me tell you that it is one of the most fruitful webinars that we've had because all of us have gained a lot by participating in this webinar. So thank you very much. If there's anything that Prakash would like to add before the closure.
Yeah, thank you once again. There's nothing more to add. We will not stand before you and your dinner. Okay, so we'll come back with another episode soon.
Yeah.
Jane,
the next one is cardio-gastroenterology.
Yeah.
Okay then, bye.
Okay then, bye. Good night.
Thank you, sir. Good night. Good night to all.